This program is sponsored by the Spine and Orthopedic Institute at St. Vincent Charity Medical Center. Quality you can believe in. And co-sponsored by the Joint Implant Surgery and Research Foundation, dedicated to the advancement of total hip, knee, and shoulder surgery since 1971.
Good evening. I'm pleased this evening to have with us three very experienced total joint surgeons, two from Cleveland, Ohio, and our guest, Dr. Harry Rubash, who's Chief of Orthopedics at Harvard Mass General Hospital, who just arrived into Cleveland. And we thought we'd take this opportunity to do a little interview and talk about the state of the art of total hip arthroplasty, some of the trends, new technology, and maybe even a few questions and answers on the future of healthcare and what we're facing in these economic times. To my immediate left is Dr. Audley Mackel, who is Chief of Orthopedics at St. Vincent's Medical Center. And to my immediate right is Dr. Harry Rubash, our guest who just arrived from Boston, again, who is Chief of Orthopedics at Mass General. And my co-host, Dr. Lou Keppler, who is the co-director of the Spine and Orthopedic Institute at St. Vincent's Charity Medical Center. And at this point, I would like to ask Harry, you're coming to Cleveland, so it's a rare opportunity with your schedule, and what's bringing you to Cleveland? What is your interest in the next day and a half that you're going to see and maybe share with us?
Well, I was hoping to see an Indians game, actually, after that great win over the Marlins a couple of years ago. But I'm here to see some surgery, give a lecture this evening, and see some surgery. I have a distinct interest in some shorter stems and proximal femoral sparing devices, so I'm here to see some surgery and visit with some friends.
And Dr. Lou Keppler has had the opportunity to work on this new design, this new technology. And Lou, if you wouldn't mind discussing how you got interested in this and where you're at in your current practice on total hip arthroplasty.
Well, as our patients change, their demands change. We have younger patients, more active people, all the baby boomers, and we're all part of that group, I guess. We have different demands placed upon us as far as getting people's function, to a level that they're satisfied with. And the hip stems are great. We might be very satisfied with them. The existing hip stems were great. And look at our x-rays and we say, boy, that's a good looking stem. But I think we could have done better with respect to preserving muscle function and preserving soft tissue with our surgeries. And so when you showed me your idea with respect to a short stem design, I was most interested in it, not for how much bone we were sparing, but primarily for the effects it was going to have on our soft tissue dissection and preserving the muscle function of the hip. So that's what piqued my interest in it.
And Dr. Mackel, we've had an opportunity over the years to be at many continuing education programs together, and you've been following some of this technology. And what are your current thoughts on total hip arthroplasty today?
Well, I think we all, as Dr. Keppler discussed, are evolving with our technology in total hips. I'm sort of a traditionalist and still cement some stems in older patients, because I think their function it seems to be quicker. But in our younger patients, I'm quite concerned about leg lengths, getting patients anatomically fit where their muscles tend to work and function as they originally have functioned. And I think with some of the traditional stems that we use, both cemented and non-cemented, I think many patients have difficulty regaining a quick postoperative function because their leg lengths are off, their offsets are off, there's something anatomically different about how they function, and that may have something to do, as Lou discussed, with tissue sparing issues. So I'm interested in how to kind of continue to rapidly improve our patients' rehab postoperatively so they can get back to their function, especially both the younger patients, but also I think even on our older patients, because they seem to be so significantly debilitated by their hip disease.
Dr. Rubash, you certainly, with your position and your international experience, see trends, and what do you see as the current concerns with total hip arthroplasty, and possibly in the next 3 to 5 years what we're going to be faced with in the way of economic trends and restrictions possibly of using some technologies that are currently available?
Well, that's a great question. I think the dominant overriding problem in hip surgery used to be osteolysis and wear. So I think coming out of the 80s, we had bone resorption with cemented stems. We had bone resorption with uncemented stems. And the question was what was driving that. And a lot of labs, our laboratory as well as others, sort of unraveled the picture that it was particulate debris that was driving this bone resorption in arthroplasty. And it was that osteolysis which was the overwhelming, I think, issue. The solution for that has been low-wear polyethylene and new bearing surfaces. So we have cross-linked polyethylene now in its 3rd or 4th generation. We have ceramics and improved ceramics. We have metal on metal, and we have ways to control the wear. Now, each of those new implant designs or new materials have issues. Cross-linked polyethylene has low wear, but it may have in its 1st and perhaps 2nd generation some mechanical issues. Ceramics have their issues. They limit what we can do intraoperatively. They break. Metal on metal, there's this whole field now of pseudotumors, metal ion release, et cetera. It's an active area of investigation. So I think right now, if you look at hip arthroplasty, we have this whole issue of hard-on-hard surfaces that we need to unravel. Ceramics also, I forgot to mention, we've got squeaking hips. A woman in our department recently came down the hall and she said, "Dr. Rubash, can you hear that?" And I said, "Yes, I can hear that. I heard it when you came around the corner." She said, "That just started." And she had a hip put in 6-some years ago, and it's now begun, a ceramic hip that's begun to squeak. It was done at one of the other institutions. So I think those are overriding issues. Materials, as far as implant ingrowth, I don't see as a major issue. Certainly there are things that we can do to improve our fixation, and what I'm looking at is ways to improve fixation earlier. So how do we drive the implant to get earlier stability? As you all have alluded to, restoration of the biomechanics of the hip is critically important. And we have systems now that deal with independently dealing with offset and dealing with head height, so that you have ways of interchanging and in one particular system of understanding this interplay between offset and head height and leg lengths. And as we know, rarely do we restore leg lengths. Our patients want their leg lengths restored. The final comment I'd make is on, I think stem design and stem geometry, at least on the femoral side. I'm looking for ways to fix that implant reproducibly in the most proximal bone possible to preserve that bone stock in the proximal femur and to provide, as we alluded to, the proper biomechanics. So I think there's a fair amount of opportunity in that latter point.
Sponsored by the Spine and Orthopedic Institute at St. Vincent Charity Medical Center. Quality you can believe in. And co-sponsored by the Joint Implant Surgery and Research Foundation, dedicated to the advancement of total hip, knee, and shoulder surgery since 1971.